I'm here today with a good friend of mine. We've known each other for quite a few years. I interviewed him in a couple of my books, and I am pleased to introduce Dr. James Forsythe of Nevada. And he is a very interesting kind of oncologist because he's also got his homeopathic license. And when we first started talking, I said, why, and I'm going to ask you this question again so you can answer it, why, as an oncologist, would you go back to school to get a homeopathic license?
Excellent question, Suzanne, and it's so good to see you again.
Thank you.
Of course, I was a standard conventional oncologist from the time I really finished my fellowship at UC San Francisco. I know you're from the Bay Area, so you know it well.
Right.
And I was doing just cookbook oncology. You take Betty Crocker off the shelf, and that's it. Use the same doses for every patient. One size fits all is how they plan it, and it just wasn't working. And then I began to go to conferences, some of yours, some of the A4M, some of ACAM, some of our homeopathic meetings, and realized that conventional oncology wasn't hitting any home runs, Susan. They were batting a 2.1% after 5 years of chemo for stage 4 disease in adults. And I really thought I could do better. I happened to be in a community in Nevada where they had naturopaths and homeopaths, and I was seeing their patients, and it frankly didn't fit the usual paradigm of how they were doing. They were doing better than our patients who were getting surgery, radiation, and chemo, or what we like to call cut, burn, and poison.
Right.
And so I figured, in order to push the envelope and to do a better job and get a better batting average, so to speak, I had to get my homeopathic boards in order to allow me to do things that I couldn't do under medical boards alone.
Like what would that be in a cancer protocol?
Well, that would be giving IV natural things like vitamin C, like peroxide, Suzanne. Mm-hmm. And it would be doing outcome-based studies, which I've done a number of them over the past 15 to 20 years, first with PAWPAW, then with Poly, then with our Forsythe immune protocol, and now with our latest one, Suzanne, is a 1,200 patient study at 6.5 years using the Forsythe immune protocol, which is really everything tied in, which starts with genomics and then starts with our immune.
Well, you know what?
Treatments and adds the low-dose insulin potentiated light therapy.
Right.
And we're doing awfully well. Our statistics now at 6.5 years survival at 6.5 years, not 5 years, but 6.5 years.
That's a remarkable progress. What I found so interesting when we talked for the first time was that as a standard of care oncologist, you're not allowed to administer vitamin C, right?
No, they don't allow it. And even places like Kaiser, which is very prominent in California, even if you talk to patients about diet and nutrition and supplements, oh, you're not going to get that promotion at the end of the year, and you're dinged. And they're encouraged not to use it. And the VA hospital, incidentally, is the same way, Suzanne, that you're not allowed to talk about anything outside of the standard protocol.
And yet, homeopathic medicine is such, to me, makes so much sense when you're going to assault the body with chemotherapy that you would need to build up the body, build up the immune system. It just makes sense. You were the first doctor who ever told me about chemosensitivity testing. And I remember I said, what is that? Can you explain chemosensitivity testing, which you do?
Yes, it has many names, as you know, Suzanne. It's also called gene testing, DNA testing. Liquid biopsies is a prominent right now, because you actually can biopsy any part of the body through your circulating tumor cells. So this really, it all really is depended on the fact that the Human Genome Project was completed in 2003, and that led the way to being able to look at the cancer genes themselves and their DNA to find out and to dictate to us as oncologists the best drugs, the best targeted agents, the best supplements, and that would include vitamins, minerals, and herbs, and the best hormones if it was a hormone-driven tumor, Suzanne. So really, I'm handing the patient a blueprint which they have not had up to this time.
And you know, you and I were talking before we started taping that it has been typical in a cancer protocol that patients are advised not to take hormones, and yet you I do not agree with that, right?
No, that's part of our it's an optional program that we offer patients, saliva testing or blood testing. For instance, in a prostate cancer patient, we're not dead set against giving testosterone with active disease, because we feel that if you can control the estradiol and the estrogen factors, that is quite safe. And as you know, it's a very controversial area. But even in ER positive or estrogen positive breast cancer, Suzanne, patients can still take progesterone, DHEA, testosterone, and cortisol. We don't give them growth hormone because the FDA says that's a no-no. I personally don't think it does anything to promote cancer, personally. And talk about that if you want. But anyway, I do feel these are valuable, even for non-hormone-driven tumors. Building a patient's testosterone and the females, their natural hormone levels, their estrogen, progesterone, testosterone, makes them feel so much better when they're going through therapy. And so there's no question in my mind that it is helpful.
Yeah, when I was had cancer many years ago, and my doctor said you have to stop taking your hormones, I said, "Oh, I can't do that." I said, I'm not the same person without my hormones. They make such a major difference. And here I am 20 years later. So clearly they weren't the issue. But there are other doctors now who are administering with prostate cancer testosterone, and they do that in Europe, right?
They do. It's much more widely used in Europe, and of course, complementary medicine in general, in Germany, France, Switzerland, Italy, is much more commonly used alongside of conventional medicine. In fact, sometimes the pharmacies are combined. Suzanne, I'm sure if you've been in Italy, Germany, or France, you've seen the standard pharmacy is there, but right next to it is the homeopathic pharmacy or the naturopathic pharmacy.
You know, it's something that I would love to instigate in this country, and maybe with Secretary Price right now, which is bringing forth the notion that alternative protocols should also be covered by insurance, just as it is in Europe, because I'm sure a lot of patients that come to you would love to have that option, right?
They would. I'll tell you a quick story about that, because we are an all-cash practice, and we have a global fee that we charge our patients for the 3 to 4 weeks of treatment we give them. But sometimes the patient will say, well, this is too expensive for me, and I'm going to take what you gave me with the genomic results and go to my standard oncologist and have him apply it. Well, I said, well, that's up to you, and we do give you that option. Of course, they probably will not do IPT. In fact, I know they won't. But then oftentimes, Suzanne, they will come back 3 or 4 months later and says, with the co-pays I pay and the deductibles, I should have come to you because I'm spending more money now.
Right. Can you explain IPT, insulin potentiated therapy, to our viewing audience who may never have heard it, and what are the benefits of it in terms of a cancer protocol?
Well, it makes a world of difference. We're only giving a 10 to 15% dose, and we're giving it with insulin. I've modified the original Donato Garcia Perez formula, where you have to push in the chemotherapy at the therapeutic moment. That would be when the blood sugar falls to 40 or below. By putting the insulin right in the bag, Suzanne, with the chemo, we do just as well without all the horrible side effects of hypoglycemia, which can be quite dramatic and quite devastating. We've never, fortunately, had a patient have to go to the hospital because of low blood sugar or any side effects with that. And our results mirror the fact that we're doing very well with it. So you don't need, and it's very much easier on the staff, incidentally, because they don't have to constantly check the blood sugar every minute. And sometimes they overshoot and the patient's blood sugar is down at 20, and then you've got a patient in distress.
That's it. When the blood sugar goes that low, that's when the patient just is completely depleted of energy.
Yes, they are. They often are hypotensive. They're sweating. They may have mental hallucinosis. They can demonstrate all kinds of bizarre behavior, pulling the IV out, running up and down the room. We've seen it all in the old days. But with the way that I give it, which is called the insulin potentiated light therapy from my protocol, we don't get any of those side effects. So it's much easier on the staff. Patients, as well, with a bag over their face, they're not bald. They don't have all the adverse side effects, and you know them all, Suzanne, as well as I do, with organ damage, with chemo brain, with neuropathies, cytopenias, and even death. Remember, an oncologist can kill a patient, believe it or not, with the first or second dose of chemo, and yet walk away without any liability or any guilt because he's done everything according to the book.
Right.
It's an all cookbook.
Well, that's where I find you so courageous, because as a trained oncologist, to go against the standard of care does not make you popular in the community, right?
Well, actually, in Reno, everyone knows what I do, and I'm old enough, so I've taken slings and arrows. It really, and I'm pretty thick-skinned. You know, I got a little Polish German in me with some Scotch-Irish.
Plus an Army background.
Army background. I can take it, and they all know what I'm doing, and I do get local referrals, believe it or not, but 90% of my patients, and much of it thanks to your knockout book, come from all over the world. I've had them as far away as Perth, Australia, Africa, many from Canada, England. It's amazing, the diversity and the fact that there's the niche that I have is not very prevalent anywhere in the world, Suzanne.
Well, because your niche is integrative, you take the best of both and combine them. I'm surprised you probably will be getting Chinese patients, because Knockout is the #1 book in China right now. So I wouldn't be surprised if you get some people from there.
I've had a recent one from China, in fact.
Yeah.
Breast cancer.
Yeah. So what's going on in the cancer world that what else? There's insulin potentiated therapy, but I see also that you're doing fractionated low dose chemo. What is fractionated?
Fractionated means instead of giving a full dose every 2 or 3 weeks, Suzanne, we're giving a 10% dose twice a week for 3 weeks. That means if you added all up 6 treatments, that would be about a 60% over the 3-week period versus the 100% that they would get in a conventional oncology infusion center. So that it is less, and it's fractionated, means you're giving the patient time to recover. Then sandwiched in between the 2 treatments, Suzanne, we give immune IVs, and that would be high-dose vitamin C, the L-glutathione, the peroxide, the Forsythe immune protocol, which is like a Myers cocktail, and the poly-MVA, which I'm very high on and have done probably several thousand patients on poly in itself. And it's a wonderful product because it stimulates apoptosis in the cancer cell, and the body rids itself of the palladium quickly, so there's very little toxicity.
So poly-MVA, for those people who've never heard of it, can you explain what it is, how you take it?
Yeah, it can be taken orally or IV. The IV method is about 15 to 20% better, as I've determined from my studies. But it's a complex of palladium and lipoic acid tightly bound with some other vitamins and minerals added to it. Coenzyme Q10 is always given with it, Suzanne, so that's a necessary part of it, but it has to be given separately.
Mm-hmm.
And when it's taken orally, it's 2 teaspoons 4 times a day is the standard dose
And I would
that I've
imagine,
used, but you can go up as high as 4 teaspoons 3 times a day.
and there would be no side effects with that. I mean, arlipoic acid, glutathione, and the vitamin C. These are immune building kind of supplements, right?
Right, you're actually sandwiching, and what I like to tell patients, Suzanne, is that we're hitting you with low-dose chemo 2 days a week, but sandwiched in between each of those treatments is an immune-building IV. So we're stimulating your good immune cells, your B cells, T cells, natural killer cells are getting revved up in between, so that the end result is that you're not beaten down by the chemo,
Right.
and you're not experiencing the side effects.
It makes so much sense. I remember the first time we talked, I thought, why wouldn't this be part of the standard of care? But I do know the answer, because, they don't want us to know that there are natural treatments. And that's part of your courage and getting your homeopathic license. What is the most common cancer that's walking through your door these days?
Well, the big 4 are always the most common. Breast and prostate are certainly the 2 most common, and that's followed by lung and colorectal, Suzanne. But of course, lung cancer is the most common cancer in both men and women. But many times they don't get to me in time because the survival rate, the 5-year survival rate in conventional medicine for any stage is less than 5%.
And when you have lung cancer, do the symptoms take a while to reveal themselves, or is it a process of listening to the language of the body, like this doesn't feel right? What do you feel when you have lung cancer?
Well, many patients like yourself are very intuitive, and they understand their body and its signals.
Mm-hmm.
So a chronic cough that doesn't go away, say after a head cold or a flu, where the cough lingers for 6, 8, 12 weeks, there's a problem there, and they need to follow up on that with scans. Now, I tell all my patients, Suzanne, to avoid the high voltage scans, the CAT scans, the PET scans, and the bone scans are no-nos as far as we're concerned, because they hurt your immune cells. Your B and T cells are very radiosensitive. They will die off easily if you promote these tests. Now, they make a lot of money for the radiologists and the hospitals, but they're not really doing the patients any good.
Well, correct me if I'm wrong, but what I had heard was that with CAT scans, there's 1,000 times more radiation than they thought. Have you heard that?
Well, it used to be that a CAT scan was 400 times the dose of a chest X-ray. Now, PET CT combined is about 600 times the dose that you would have under a normal chest X-ray. 600 times. Imagine yourself, Suzanne, standing in front of the box, getting a chest X-ray and wondering, if I do this 600 times, would I be hurting myself?
Yeah.
Oh, I don't think so.
That's an easy question to answer. So if I'm a cancer patient, which I don't want to be again, and I don't plan to see you under those circumstances ever, I think if I walk in, the first thing you're going to do is, after the diagnosis, you're going to send my blood to Europe to do a chemosensitivity test. Is that still part of your protocol to see what, correct me if I'm wrong, what I understood from when we first talked was that not all chemos are the right fit for all cancers. And so you send it off to get a chemosensitivity test to make sure that the chemo that you are recommending for this patient is the right fit. Am I correct?
Absolutely right. Remember, if I'm giving you the wrong chemo just because I've used the standard protocol, it's hurting you. It may actually speed up your demise. So that way, when you're doing chemosensitivity testing and looking for, say, the 2 best drugs over 80% effective, Suzanne, you know that the patient is going to respond. In fact, That plus a 16 or 20 natural supplements, which may have efficacy rates anywhere from 5% to 60%, are also adding. It's like adding a lot of ammunition to a target. I always tell them about, going after Osama bin Laden with the gunships and the cruise missile offshore and the grenade rifles and so on. And the more you're putting on a target, the more you're going to likely to have a kill. And I said, the enemy here is your cancer. It's not a Islamic radical.
Right. Right.
So, and maybe that's, and I'm an old Army guy, so I probably shouldn't use that.
No, I like that about you. And by the way, thank you for your service. So you if the patient is a candidate for chemotherapy, now you've established that they are going to get the right kind of chemotherapy, because I do recall, and I'm not speaking out of turn here, she's no longer with us, my friend Farrah Fawcett, who called me when she was at 87 pounds and in katsitia, which is when the body starts eating itself. And she said, I had 3 rounds of chemotherapy and I found out none of them were the right fit. All it did was just degrade my body. And what do you say at that point? So I think that what you're doing is so important. So now you've created the right fit. Then 2 days a week, they're going to get their low-dose chemotherapy. And then in between the week, they're going to get their homeopathic detoxification drips, which would be the arlipoic and the glutathione and the C?
The C and the peroxide and the virus cocktail with DMSO. We have those are all set protocols, and they've all been found to really jazz up the immune system and make them better able to fight the cancer. We're actually reinforcing their own inherent intrinsic defense mechanisms, Suzanne, so that they have the power to respond maximally. And here's another interesting thing that you might not realize. When you give the 2 best 80 drugs plus 16 or 20 supplements that all work, because they all have the name of the patient on them, that's their DNA. The University of Utah has done a calculus on what this means in terms of their likelihood of a remission, and they come up with a number 95% or greater. So I can tell the patients that mathematically, when you're adding this much ammunition to their treatment course, they're actually going to be in that 95% or greater curve, if you know what I mean.
Yeah. And then at what stage do you're talking about bioidentical hormones, right?
Yes, only bioidentical hormones.
So at what stage then would you start the alchemy with getting their hormone balances right?
Well, we do that initially. We like saliva testing preferentially over blood testing, Suzanne. But we would start that anytime during the course of their treatment. And we would also do thyroid testing. Some of them want to have growth hormone testing in the form of IGF-1. That's all optional. Those are optional because they are costly tests. And the growth hormone, of course, the FDA says no to that, so we stay away from that.
That's too bad. It's the lack of understanding on a government level, where we used to make a human growth hormone in our body up to a certain age. How can it be bad to put back something that the human body made? But, I could go on and on about that. Now, say that again.
You and I feel the same on that. And there's data suggesting, because they're inverse curves, Susan, because as you get older, cancer increases, but growth hormone decreases. So they're crossing curves. One's going down, one's going up. That doesn't make sense. Also, young children who've had large doses of growth hormone have not had a higher incidence of cancer ever in any of the studies. So several things, go against that theory.
Well, it's the same thing with estrogen. Or testosterone. If estrogen gave you cancer or testosterone gave you cancer, every young person would have cancer because you're oozing it. So it's all about the ratio. I often wonder, I had an estrogen dominant cancer. If I had a doctor at that time who was in the know, and I wasn't, and this wasn't around at that time, if I had been doing baseline testing and replacing my decreasing progesterone levels,
Yes,
I might not have gotten cancer. Do you think?
it's possible. It's
Yeah.
very possible.
Yeah, because so many doctors tell their female patients, you can't take estrogen anymore once you've had cancer because you're estrogen dominant. And I've always thought, then what about replacing progesterone and getting that ratio back? Anyway, I digress. Now, nutrition. Do you give them a dietary program, and how important is organic food?
Oh, extremely important. We go over that in detail. We go over pH balancing and nutrition, and I have a book out now, the Forsythe Anti-Cancer Diet. But I always tell them, Suzanne, that there is no one single diet for every cancer patient. Some do well in the paleo, some on the Atkins diet, some on the Mediterranean diet, some on the zone diet, some on the Budwig. So it has to be something that they can tolerate. Obviously, most people can't tolerate doing the Budwig all the time. Cottage cheese and flaxseed oil just does not cut it with most people. Or the Gershon diet, which means no fruits or grains and 4 to 6 colonics a day. Well, very low compliancy with that diet.
But it makes sense to me. Feed it right and clean it out. Feed it right and clean it out.
Yeah.
It's basically
those things are all important.
Yeah.
And the more faithful I said, if you're really faithful to this diet, you will lose weight. And I can tell whether or not you've been faithful, because all cancer diets are weight loss diets, basically. They're pushing aside high glycemic carbs and sugars. So you're going to lose weight. Now, if a patient is cachectic to begin with, that's a problem, because you're going to lose some more weight if they're doing it right.
And they can't eat, right?
Yeah, exactly.
At that stage, yeah. So if a patient is at that stage and they can't eat, can you take all those supplements into some kind of liquid form and give it an IV?
All the supplements, and they're probably going to be 16 to 20. They sometimes have to crush them up, put them in a smoothie, empty a capsule out. Some of them, like the poly, are liquid, or the moringa juice, that's liquid. So we have some liquids, but you're right, it can be a problem. And I have them divided up and grazed during the day, maybe every 4 to 6 hours. Take 4 to 6 of them or put them in a smoothie. There are ways to do it to make it, we encourage that.
A good friend of mine, and as I wrap this up, is Dick Van Dyke. Remember Dick Van Dyke? He's 92 years old. Yeah. He does not have cancer. Dick Van Dyke is the healthiest person I know. He's got his brain, he's got his bones. He can still lift his leg over his head. Every day, he takes all of his vitamins and everything in a mortar and pestle, and he grinds it up. And I said, Dick, why would you do that? And he said, because I've heard about cadavers. When they open them up, there's a bunch of undissolved vitamins in there. He said, I want to get everything out of these. So he's a wonderful example of health. Is there anything, we're going to close up now because this is the fastest half hour I've ever had. Interesting information as always from you. You are located in Reno, Nevada, correct?
Yes, 521 Hamel Lane. Reno,
Hamel, like my husband's last name?
My husband's name.
What a small world.
One thing we're looking at, Suzanne, just to get this in, we are looking at cannabis oil for maintenance, long-term maintenance, and for essential oils. We're now looking at using some of the essential oils like frankincense and myrrh, remember from the Bible?
Yes.
The wise men. And that also contains rosemary and sandalwood and clove. And oils today they're coming of age again. I actually anoint my husband. I always say, I'm going to anoint you like baby Jesus every night. I put frankincense and all, and I don't know what it does for him, but he likes the attention. Yeah, frankincense is very important.
Yeah, well, if it was good enough for baby Jesus, huh? What a pleasure to talk to you, and I hope to talk to you again soon and give my love to your beautiful.
Great, and I can't thank you enough for all your help with my practice.
Yes, and goodbye.
Bye-bye. This is Marlene. Thank you.